All right.
Happy Friday and welcome everyone. Thank you so much for being on time. We've just been catching up just to make sure we had a pretty good sound check. So I hope everyone can hear me okay. Once again, I am Dr. Ardarian Gilliam Pierre. I am board certified in family medicine and geriatrics.
And I'm Dr. David here. I am board certified only in family medicine, not like my co-host, but I make the best of it.
I'm so excited to have Dr. Douglas on today. Recently, we were able to serve on a a community panel, and we all were able to share the stage. And I just felt like we had a little bit of unfinished business and topics and things that we could give to the community. So thank you, Dr. Douglas, for saying yes. I'll take a moment to read your bio because you're so extraordinary, and then we'll get started. Dr. Analise Y. Douglas was born in Washington, D.C., and raised here in Ridgeland. She completed undergraduate training in the Honors College at Howard University in D.C., where she graduated cum laude with a Bachelor of Science in Biology. She went on to University of Mississippi Medical Center to attend medical school, and then she went to Rutgers, New Jersey Medical School in Newark, New Jersey
Ooh,
for her internal medicine
Rutgers.
residency. I knew he was going to say that. During her time there, she was honored with the Golden Gold Humanism and Excellence in Teaching Award. Dr. Douglas then attended the University of Connecticut at Hartford Hospital, where she completed her cardiovascular disease fellowship and her interventional cardiology fellowship. She enjoys speaking with churches. She's board certified in internal medicine, cardiology, and echocardiology. Now, that's that magic that I love. She's a member of the American College of Cardiology, and the Society of Coronary Angiography and Interventions. She lives with her husband and her sweet daughter in Jackson. And in her free time, she enjoys running, reading, traveling, writing, and attending church at Redeemer. Thank you, Dr. Douglas, for saying yes. Thank you for being here today, and we'll get started.
Thanks for inviting me.
Yes. So just go ahead and tell us, how did you decide to become a cardiologist?
Well, to be honest with you, I wanted to do primary care. And I loved the doctor-patient relationship that primary care doctors have with their patients, and I still love it. A mentor of mine actually made me think about, and she was like, in some of the subspecialties, you would still be able to have that same doctor-patient relationship. So there's more than primary care in case you open your eyes to other things. And so from there, she actually mentioned, she was like cardiology, they have long-term doctor-patient relationships. So I went to residency and I found that I actually love cardiology and I love learning about the heart and I love teaching people about the heart. And it's actually, of course, it's very important for people to know more about cardiovascular disease. And so that was kind of how I got started on my journey, was like actually from a mentor mentioning it and then kind of seeing for myself in residency, oh, this is actually very cool. And I would be able to still have that relationship with patients that I always wanted, like you get, Dr. Pierre, Doctor's Pierre.
Well, thank you so much. We're number one, Mississippi. We're so blessed to have you here. Our community, we're blessed that you chose us. We know that you've been around the world to train, to learn, and you decided to come home. So thank you for being here. From a primary care perspective, I know us, we are not cardiologists. We often are always educating folks about wellness and lifestyle changes. From your standpoint, a cardiologist standpoint, tell us about the importance of lifestyle things that you do every day, those little bitty changes that you need to implement in your world.
I love that you said that because really the primary care doctors and cardiologists and subspecialists work hand in hand to make sure that all of the lifestyle changes that we recommend are implemented. So I love when patients come in and say, oh, well, my primary care doctor told me to reduce salt. We'll talk about that later, but told me to reduce salt in order to control my blood pressure. I can then build on that foundation of course they said that, and this is why, and this is how we're going to do this. And I love that kind of working alongside primary care in order to do that. So it's very important to implement small things, like you said, like exercise. Small dietary changes make a big difference in blood pressure control, in controlling other risk factors for cardiovascular disease. So I actually am very passionate about doing the lifestyle changes. And I think that a lot of people think that because I'm a doctor, I am primarily going to push medications. Honestly, for a lot of the diseases that we see, the first thing we do is lifestyle changes. And I mean, that's something that you talk with your doctor about and you work alongside them to make a plan. But it's not always medicine, medicine, medicine. For some people, it's, hey, treat exercise like your medicine right now. Treat getting on that treadmill as if it is a pill. And I love kind of coming alongside of my primary care doctors that work alongside me to basically emphasize that.
Thank you, Dr. Douglas. So since we're talking about these things, let's go ahead and give our audience the numbers that they need to hear, the ways that they can strive for, or the things that they can strive for when we talk about exercise. So tell us, what are those numbers when we think about how much time we should put in within a week?
So I actually usually say 150 minutes of a moderate intensity exercise. But actually recently on that same panel that we were talking about, Dr. Hardiman said it better than I said it, which is exercising for 30 minutes more days out of the week than not. And I think that that's just a simple way to think of it, is just getting your 30 minutes in. Now, this is after you've seen your doctor and they've cleared you to exercise. Some people should not be exercising in specific conditions and situations, but 30 minutes more times a week than not is kind of the recommended. And some people ask me, well, what is moderate intensity? And I always tell them it's probably less than what you're thinking. I say that moderate intensity is about like you're maybe a little bit short of breath as you're walking, basically that amount where you're like, okay, I'm working a little bit here, but not sprinting. And I think that a lot of people, they go out and they expect to be sprinting on day one when this is the first day of their exercise regimen, which is not realistic. And I don't think that you would expect that from anybody else. So I always just say 150 minutes or 30 minutes more days than not of exercise, of moderate intensity exercise. Sorry, one of my apps just popped up. But I think that once you kind of get into that routine of doing that same thing over and over again, it becomes like a habit for you, and then you desire to exercise and your brain changes to expect exercise. And once you make one lifestyle change, then the other ones are much easier to then implement.
I often use this for my patients as well as my children. How do you eat an elephant? Just one bite at a time. So start small, like Dr. Douglas said. So, what are the cholesterol numbers? I've had a lot of questions from patients and even friends. And so we know those recommendations have changed a little bit. So when you think about the numbers for cholesterol, oftentimes patients, they're able to pull up Epic and see red or see yellow. Tell them how to approach this before, without a panic, I guess.
So I would say don't panic, but you should know your numbers, particularly if you have to look at that cholesterol panel and figure out which one is the most important number. The number is the LDL, or the bad cholesterol. So LDL number is directly associated with risk of cardiovascular disease. That being said, we no longer just treat numbers in medicine. Medicine is very nuanced and very specific to the patient. So that means that some people with just elevated bad cholesterol may not need a medication for that immediately. What we usually do, and what your doctor will probably do, is sit down with you and calculate your risk of a cardiovascular event over a 10-year time period, which is actually what the recommendations are now. There are ways to kind of say, okay, because of your cholesterol plus something else, you may be a higher risk person. For instance, if you are also a diabetic, that also increases your risk. And if you're a smoker or you have a family history of heart attacks at younger age, all of these things are things that your doctor will then take into account along with the number of your cholesterol. But it also is just important to know that number, your LDL. And I never say that you should panic necessarily. And some people have this bad language toward cholesterol, saying, oh, you're a walking heart attack. I've had patients come to see me and say, they told me I was a walking heart attack, help. And I'm like, I don't think so. Or you having chest pain? And so I kind of have to walk them back and say, okay, this is good that we found this, because now we can do prevention, which I know all of us are very passionate about, preventing cardiovascular disease before it even starts. So that's why I say the LDL is one of the most important numbers to know.
Okay.
Oh, go ahead, Dr. Pierre.
You touched on salt a bit, and I've been accused of using maybe a little too salt at times, and some other people have been accused of not using enough salt. Uh, so, what is your theory on salt? Why is it good? What is bad? What is consumption, etc.?
So I would say that there are people who are very salt sensitive, right? There are correlations with high blood pressure and too much salt intake. There's, of course, heart failure people who, it causes them to retain fluid and maybe increase their risk of hospitalization. So those are specific populations where you would basically say, okay, you have a specific amount of salt that you should be eating. However, it is important for everybody to know just how much salt they're consuming in a day, because I think that what has happened to us is that we're not reading nutrition labels and we're not realizing just how much of the things that we're eating, how much of the nutrition that we're eating from what we're consuming, essentially. And the reason I say that is because I've had a lot of patients come in to see me who are saying, Doc, I don't know why my blood pressure is high. It's been high all of this time. And I'm like, well, just run me through what you're eating in a day. And they'll tell me multiple salty things that they don't realize. And maybe the word for salt is not correct. We should use the word sodium in order to identify and capture the amount of salt that people are eating. So everything that you eat, I always say, pick up the back and you need to at least know two things. The first thing is the serving size, right? So it doesn't help you that you get a sleeve of Pringles, right? And you think the serving size is the whole thing when truly it's 15 chips. I can say this because I've looked at it, right? Because I like Pringles. So 15 chips. So as you're looking at the serving size, now in those 15 chips that you're consuming, there is 8% or so of your sodium for the day. And that's a snack, right? Now, in addition to that, your full meals that you're eating, if you're looking at the back of your seasoning salt, if you're eating anything that's very seasoned, you have to know what the serving size of that is too. I can use Tony Chachere's as an example, is one of my favorites. Each teaspoon of Tony Chachere's is 15% of your sodium for the day. And so if you calculate it out, saying that you have 3 meals a day and you're eating more than a teaspoon of the seasoning salt, whichever one it is that you like, then a lot of people don't realize that they are eating way over the 100% that is calculated in that percentage on the nutritional facts on the back of everything. So it's very important for people who have high blood pressure. And so I see that somebody asked, what is the total amount of sodium that basically you should be eating in a day, maybe? Since we're on it, I do want to just touch on it. It's not necessarily, so people with high blood pressure, you should be aware of it. And the recommendation is like, I think 2000. I always say, whatever you're eating now, decrease it, right? You have high blood pressure now. Let's just decrease it. Wherever you can find extra sodium to remove, just remove it. For instance, pickles each pickle has 30% of your sodium for the day, which I didn't realize until somebody came in and said they love pickles. And then all seasoning, it has a lot of sodium in it. So I would say just whatever you're eating, whatever you're consuming, just be aware of it. And with the nutritional facts, it always has a percentage value for the day. So if you're eating and you realize that you've eaten several things that equal to more than 100%, you know that you're eating over the 2000 milligrams daily value that is recommended. Whew, that was a lot on sodium. I'm sorry.
That was some good information that we all need. So thank you very much. So since we're talking a little bit about sodium, I know there were some changes as far as a healthy plate. Can you describe to folks what's a plate, right? So what are you telling your patients as far as a healthy plate?
So a lot of my patients, they come in just not knowing like what they should even be eating. And so I just say a good way to start out is just eating more veggies and fruit. Now, diabetics are in a whole different category. Their diet is very specific, but most people are not getting their daily recommended amount of veggies and fruit. Who remembers the pyramid that we used to have in the 90s, like the food pyramid? Nobody could tell. Is it that on the top of the pyramid is the most important, or is it on the bottom of the? Nobody knew. And so the government, I'd say the FDA, the CDC, they made a different model which helps us with how our plate should look. It's called My Plate, which is Dr. Pierre is referring to. And the general gist of My Plate is that in your plate for lunch and dinner and even breakfast, half of your plate should be fruits and veggies, right? Then the other quarter should be a starch, and the other quarter should be a protein. And I think that for most of us, our plates lean more toward the starches, lean more toward the protein, and there's not nearly enough veggies. And so the diet that we're eating is not reflective of the best or the recommended diet for healthy living. So that's the healthy plate that you're referring to. But whenever my patients come in and ask me, what should I be eating, doc? I just tell them however much veggies you're eating now. And I mean, non-starchy veggies, meaning the crunchy veggies that little kids don't like. So like the Brussels sprouts and the cauliflower and the broccoli and the asparagus, those kinds of veggies. Pick one that you like, right? Most people are like, I like broccoli. Pick the broccoli then and try and make it so that you're eating a certain amount of broccoli every single day so that you're getting your serving size of veggies.
Dr. Douglas, I know you have a little one. Do you have any tips for getting these little ones to eat? My youngest one, he will not touch a vegetable at home. I learned that at school, he eats all of his vegetables on the plate. So, any tips there?
So I just know which ones my girl will eat, right? I know which ones she won't even look at, and I know which ones she will eat. And so if I can just put the ones she will eat on her plate, she's more likely to pick them up and eat them. Besides that, I'm still trying to figure it out. I really am. I'll be honest with you. And there's different ways of seasoning things, different ways of preparing the veggies that there are ways and there are ways that I still haven't figured out. So yeah, but it has been shown that if you, the adult, the parent, are eating in a certain manner, they're more likely to kind of follow your lead as well. So that means that even if you have the veggies on your plate, they're more likely to look at you and say, maybe I should try broccoli. Mommy's eating them and she makes them look great, So I think that we can lead by example in that way. But besides that, I'm trying to figure it out.
I wanted to dig a little deeper into sodium. So you touched on that beautifully, excuse me. But I want you to just dig deeper and tell me, how does this affect the body? So we talked about it raises your blood pressure, and those who have congestive heart failure need to monitor. But how does this over time affect the body? I think a lot of folks need to hear that. to further encourage them, on their intake or
So
lack of?
yeah, no, you're absolutely right. I think that people don't realize that the side effects of the sodium intake, the increased sodium intake, if they're leading to blood pressure problems and eventually heart failure at times, that it high blood pressure, uncontrolled high blood pressure is a significant cause of morbidity, especially in the African American population. It's been postulated that 40% of cardiovascular disease that is increased in the African American population can be directly linked to high blood pressure that's not under control. And so if the sodium intake is one of the reasons that the high blood pressure isn't under control, if we can control that, then we can help control kidney disease, which is also related to high blood pressure problems. We can also control heart failure problems. So there's this, the way that I think about heart failures, a specific type of heart failure, is that basically your heart is a muscle. And so if it's having to pump against a very high blood, it's like you're working that muscle like every single beat. And so what happens to muscles as you work them out is that they get bigger, right? Except the heart wasn't meant to be very thick. And so after a lot of time of pumping against high blood pressure, the heart becomes very thick and becomes dysfunctional because it's not meant to pump against 200s blood pressure all the time. The arteries of the brain, of the kidneys, they all become dysfunctional because they're used to having this very high blood pressure. And that's where you see the long-term sequelae of the high blood pressure. And that can be led back to the sodium intake in a lot of people. I think that they're still trying to figure out a lot of the relationship, particularly in African Americans, related to sodium. They've thrown out a couple of things that aren't necessarily backed in research, but there's a relationship there that Black people have more prevalence of high blood pressure, and they also have earlier high blood pressure problems. And so if we can get the sodium under control, which has been known to make the blood pressure more likely to be uncontrolled, the less blood pressure problems we'll have, the less heart failure, hopefully, we'll have, the less kidney disease we'll have, the less cardiovascular disease we'll have. So that's why it's so important. And that's why I try to treat it the best I can. Anytime I see somebody with a high blood pressure, I'm like, no, you can't walk around like this. We got to get this under control.
Thank you. Thank you so much. So just to kind of piggyback on what you're talking about, I want to, or would love for you to touch on us as African Americans and how we are not really present in research. So there's a lot of information that we may not know about how our bodies may respond to different things, not just sodium, but stress and different factors that may affect not just our heart, but our entire body. So do you mind weighing in on that for a little bit for us? And I know we're getting close to time. We are going to answer some of the questions in the chat, but we'll finish my questions really quick and we'll touch on that. Go ahead, Dr. Douglas.
In order to even talk about African Americans in research, I have to first acknowledge the fact that African Americans have been abused and not neglected, been untreated in medical research in the past. I would be remiss to pretend like medical research has always had the standard of ethics that they have, we hope, now. And I'm not gonna, pretend like some of the medical equipment that we now use is not directly related to some unethical medical research that has happened in the past. But just like you said, because of this, because of African Americans' hesitancy to be in research projects, a lot of the research that that is coming out we're not represented, right? And so what that means is that we and your doctors are practicing sometimes, yes, based on a general population, but we don't know a lot of the information that we could potentially know about cardiovascular disease specific to African Americans. Yeah, we have some research that has been incidentally found based on heart failure populations. Maybe this medication versus another medication may do better in African Americans. But I'll be honest, like even those medications in heart failure, I'm a little skeptical of, because I understand that race is not biology. It's a societal construct, essentially. So I am a big proponent of research, obviously, but I also completely agree that we are not always represented in research in a manner that makes it so that we can have definitive plans based on race. That being said, I think that now we have a lot of ethical boards regarding research because of what has happened to Black people in the past. We have the IRBs. You have other doctors who can say, hey, that sounds a little funny. What are they, what is that going on? You have a community who basically can protect us now. So that being said, I am a big proponent of being in research studies, because we need to know, right? The research that I am participating in now will help my second, third, fourth generation down the line. They'll be able to look back at this generation and say, hey, we tried this blood pressure medication in Annalise's generation, and we saw that there was a 20-point decrease in blood pressure in the African American population specific to us. And I think that people are becoming more willing to be in research studies, but I would be remiss to not like acknowledge the history of why people are hesitant. So both, and yes, we need to be in more research. I also understand if somebody's like, no, I don't want to do that.
Yeah. Oh, yeah. Thank you for expounding on that so wonderfully and thorough. I know we're running out of time, but I have one more question. I really think we talked about exercise, but let's talk about obesity and the GLP-1, since this is something that, everyone's talking about it. Everyone's trying to get it. They're trying to get it from their docs. If their docs don't prescribe it, they're going online. Can you just talk to us about your thoughts from a cardiology standpoint? Of course, there are benefits, but then let's talk about those risks. Just provide some education for us, please.
So I think that this is the second time a diabetes drug has surprised us and been shown to have a significant cardiovascular benefit. The first one was the SGLT2s. And if you've never heard of those, I'm talking about like Jardiance and Farxiga, right? And some patients are like, well, why are they putting me on a diabetic medication? Well, now it's a heart medication, and we love putting people on those, and they have mortality benefit, which was surprising to physicians, right? But through our research, we've been able to find a similar thing with the GLP-1s. And that's mostly driven by major adverse cardiac events being decreased. And the primary one was stroke, from what I understand, which was surprised. We weren't expecting this kind of thing. We were trying to treat diabetes better, and they found that there has been a benefit, particularly in the major adverse cardiac events. Now, I have a lot of patients who are asking me, just like you said, should I be on these medications? The ones that I immediately start looking at are not necessarily people who are obese. They're the ones who have already had a major adverse cardiac event, right? And they have diabetes, or maybe they don't have diabetes, but they have some other risk factors that make me think that they may benefit. Those people are the ones that I will talk to about it and kind of say, hey, you should consider talking to your doctor about it. The other people that I think about that have been shown to have benefit from the GLP-1s are like the people who are obese who have one or two risk factors. And they're like, should I consider it? I'm like, I look at a calcium score, I look at a cholesterol, I look at how many risk factors does this person have. And I'm like, okay, if it can be approved by your insurance, sure, let's try it. The cool thing that I've found about these people that get on the GLP-1s, and maybe other people don't think it's cool, but people will come in and say, doc, I haven't lost that much weight. I've been on this for 3 months. I haven't lost any weight. And I'm like, no, but let's look at your blood pressure. Your blood pressure has never been controlled. And now all of a sudden it's controlled because of this medication. And so I look at the cholesterol afterwards. And in a lot of people, it's been, all of a sudden controlled after being on this medication. So I think that in certain populations, absolutely, it's been shown to be helpful. And in more than just weight loss. So that's one of the cool things about this.
Darren's internet just went out for a second.
Oh no.
Um,
Oh, there you
I
are.
didn't hear the last thing you said. Mine went out also.
Apologize. We just went out for some reason over
Can you
here.
hear me, Annalise?
Yeah, we can hear you now. I was just talking about how, like, even if they don't see the weight loss benefits, they see other benefits like cholesterol and high blood pressure benefits. So I'm a big proponent
Okay.
of them in the populations that is indicated for. Um, Oh, and you were saying about side effects. What I always tell my patients, and mind you, you guys prescribe them. I don't prescribe them. I just, give evidence that it would be beneficial. But the side effects that I see and why people end up in the hospital with the GLP-1s most frequently for me is they stop eating and they stop drinking. And those are the people that are like, oh, I just felt bad. I started vomiting. And I'm like, even if you're eating a little bit, you have to eat something, even though your stomach is not the same, your appetite is not the same, you still have to continue to eat.
Well, Dr. Douglas, thank you. I want to express appreciation for your commitment to being a catalyst to our community, a catalyst for education. We will take some questions from our audience, if that's okay.
Yeah, sure.
And then at the end, we'll allow you to just have the floor and share anything else that you'd like to share today. Dr. Pierre, do we have any more questions?
I'm sorry. I don't know what's going on with the internet. Of course, it's going to act funny, but no. I think we covered everything. We still have some more questions from there's one Marva was asking about vitamins that you recommend as a cardiologist for heart health. Is there anything that you recommend? I know we talked about that before in our last panel about it not being FDA approved. We don't know what is in the vitamins at what dosing, but um, is there anything you have to just expound on that?
I mean, so the one that most people ask me about, especially if we're talking about cholesterol, is the CoQ10. And I will admit, I'm willing to admit that there was another panel on which I was speaking about this, and someone actually from the audience educated me about CoQ10 basically being an enzyme that's depleted in people who are on statins. It's one of those things where you're like, hey, I don't know everything, but I looked it up and they were right. So they have done study after study, because if we can get the muscle aches from statin use to go away, a lot more statins would be used. It's one of the main side effects of statins. Not everybody gets it, but the people that get it, it really affects their life. And so people use that vitamin in particular in order to try and help with the muscle pains or myalgias associated with statins. What I say is, hey, if it helps you, great. Okay. If it doesn't help you, I'm not surprised. Does that kind of make sense? I've heard it both ways, where people are like, "Oh, I take my CoQ10 and it like really helps my muscle aches," and I've heard it the other way. I tried it and my muscles are still hurting. And so, if that particular one works, great. If it doesn't work, okay. Always, always, always bring your supplements to your doctor, because there are many supplements that will interact with the medications that we're using. So even if it's something that you got online or something that you're not sure about, come and bring it to your doctor. They want to see what you're taking and what you're thinking about taking before you start, so that we can have all of the information. So there isn't a particular vitamin that I recommend aside from a multivitamin in specific populations. But yeah, the main one I'm always asked about is CoQ10.
If I may just weigh in here really quickly today,
Mm-hmm.
about me, I'm very well aware of that, but I do want to add in with vitamins. I agree. So typically, unless you're a certain age or you're unable to consume an appropriate diet, really, you should not require vitamins on the daily. If you've had your vitamin D checked and that's low, okay, that's one thing. But as far as a general vitamin, there's not one that's recommended or needed. If your vitamins is in the healthy foods that you consume. We get that question
Correct.
a lot.
I
Yeah.
love that you weighed in on that.
Yeah, we are over vitaminized in the US. That's why your urine is so yellow sometimes because you just pee out all the vitamins.
All the
But
vitamins just in the toilet.
yeah,
Sad.
All
just
that money. Look at it as far as the coins go. Your
yeah.
coins
Yeah.
being flushed down the toilet. Any more questions? This has been so great. Any more questions, Dr. Pierre?
There's a question about the obesity numbers. I know we know about BMI, et cetera, and sometimes, we have the BMIs kind of on the higher side for African Americans. Are the numbers really for African Americans or
That's a good
anybody? You could
question.
touch on the history of BMIs, one of you ladies,
I think Dr.
doctors.
Pierre can touch on
Yeah,
the history of BMI. My impression is that it does not always account for African American body proportions.
It
agree.
does not. It goes back to the research that we talked about. That's going to be a general recommendation for those who were participants in that particular research. So, again, acknowledging the history of where we've come from. But when we think about the legacies and the education that, as far as us moving forward, as families, as African American families, communities, then we've got to get more active in this area so that these numbers do reflect us and our body types and our genetics. So,
Okay, thank you.
mhm.
All right.
All right, Dr. Douglas, you have the floor. Are there any amazing words you want to leave us with? Anything
Uh,
else you'd like to share?
I think that what Dr. Glenn said last panel was actually very pertinent about basically making sure that you're seeing your doctor every year. Just see your doctor, especially if there's nothing wrong. Especially if there's nothing wrong. Just having that yearly follow up is so important. And I love that he said that because getting into the habit of seeing your doctor every year so that they can have a baseline for you, so that they can know when things are changing is huge. And I think that a lot of us think that if there's nothing wrong, there's nothing to bother my doctor with. But prevention is so key. It's so important. Your yearly lab work helps to build a normal range for you that's specific to you. So I think that that's such a huge thing. So just seeing your primary care doctor every year, huge. It's more important than people realize.
Yes,
And I'm
I agree. Completely agree. I completely agree from a hospital physician standpoint. I must just echo what you said. The amount of times that I've seen mostly young African American men come into the hospital in their 30s and 40s and ending up on dialysis or ending up with, being diagnosed with heart failure or hypertension or diabetes. And pretty much for them it's almost seems like a death sentence for them, which is not. But like you said, if they go to the doctor and see a physician or nurse practitioner, PA, what have you, even when you're healthy, just knowing what is normal and then seeing what is abnormal, we can prevent a lot of issues that we have in our community. So I echo that. Uh, in the chat, I posted a link for donations to the American Heart Association. Upon your entry for this donation, you will be entered in a drawing for a Amazon gift card. So go ahead and make those donations. That link will take you to Darren's old Woman of the Year, Woman of Impact site where you can make a donation. And I turn it over to Dr. Pierre.
All right. Thank you, everyone. We appreciate your time, your energy for coming, for joining us today. Please don't just hold this information to yourself. Spread it to your friends. Spread it to your family. Just share. We will try to get this link up. So if anyone missed it, you can share it. We'll try to put it on our YouTube page. Once again, Dr. Douglas, we love you. Thank you and safe travels today. We'll be in touch.
Thank you so much for having me.
Yes.
Bye,
Have a
everyone. Thank
All
you.
right. Bye bye.